the dry mouth at 3 in the morning, the sore throat that arrives with no illness, the cracked lips that no balm resolves, the pillow with the damp patch where saliva leaked through parted lips during the hours the jaw dropped open and the tongue fell backward and the airway shifted from the passage. It was designed to use to the emergency bypass. It was never meant to sustain for the full overnight duration. Your partner has mentioned it. Your dentist has noticed the dry mouth. Your morning throat is sore without any illness to explain it. And beneath those surface symptoms, a cardiovascular event is running silently for 8 hours every night the jaw drops open. 60% of adults sleep with their mouths open for some or all of the night. Most have been told by a partner or a dentist. Some learned from waking with a mouth so dry they could not swallow without water. A few discovered it from a sleep study ordered for a different reason. Most know it as a nuisance, a snoring trigger, a dry mouth irritant, a cosmetic issue their partner mentions and they dismiss. The snoring discussion described what happens when the airway narrows, the Bernoulli effect, pressure drop across the pharyngeal walls, the vibration that progresses toward obstruction. That discussion described the airway problem. But the airway problem is not the only consequence, and it may not be the most dangerous one. The mouth that falls open at night bypasses the only structure in the body that manufactures the gas your pulmonary arteries depend on to stay dilated while you sleep. The cost of that bypass, measured in blood pressure, in cardiac workload, in the recovery window your heart was supposed to receive, is accumulating every night the jaw drops open. Paranasal sinuses, hollow cavities surrounding the nasal airway, lined with epithelial tissue, produce nitric oxide continuously. The humming discussion described this production and how sinus oscillation enhances it. What that discussion did not measure is the cardiovascular cost when the delivery route is abandoned for the full overnight duration. The concentration of nitric oxide inside the sinuses reaches approximately 25,000 parts per billion, one of the highest sustained concentrations of this molecule anywhere in the human body. Each nasal inhalation draws air through the narrow openings connecting the sinuses to the nasal passage, the ostia, sweeping the concentrated gas into the airway and carrying it downward to the lungs. 12 breaths per minute during sleep, 720 per hour, 5,760 across the full sleep period, each inhalation delivering a bolus of vasodilatory gas to the pulmonary capillary beds where oxygen crosses from air into blood. Delivery mechanism is passive. The gas accumulates in the sinuses between breaths, and each inhalation flushes a fresh bolus into the airway, the way opening a door between a warm room and a cold hallway pushes warm air into the corridor. The concentration gradient drives the flow. The breathing cycle provides the pump. The nasal passage is the only route that passes through the sinus region. Air entering through the mouth travels directly to the pharynx, the larynx, and the trachea, without passing through or near the paranasal sinuses. The nightly breath count, missed entirely across a single night of mouth breathing. Across a year, over 2 million missed deliveries of the molecule. The pulmonary vasculature depends on to maintain the dilated state the heart requires for its nocturnal recovery. You can feel the difference between the two pathways. The difference between the two passages is something you already recognize. Nasal air feels cool against the turbinates, slightly moist, with a subtle resistance that slows the inhalation. That resistance is the air passing through the narrow sinus ostia, collecting the gas. Oral air arrives faster, drier, with no nasal sensation at all, because it took the express route, bypassing the factory entirely. The nose is not merely a passive opening. It is a gas collection apparatus, a conditioning system that warms, humidifies, filters, and enriches every inhalation with a vasodilatory molecule the lungs are waiting to receive. The mouth is the emergency bypass, designed for high-demand breathing during exertion when nasal resistance would limit airflow. Using the oral passage for the full sleep period of resting breathing is the equivalent of leaving a building's emergency generator running all night instead of connecting to the power grid. The generator works. It was never designed to be the primary source. The lungs receive air either way. Oxygenation continues through both passages. The difference is what the air carries with it. Nasal air arrives enriched with nitric oxide, warmed to body temperature, humidified to 95% relative humidity, and filtered of particles larger than 10 micrometers by the nasal turbinate system. Oral air arrives at ambient temperature, ambient humidity, unfiltered, and carrying zero nitric oxide. The oxygen content is identical. The delivery vehicle is entirely different. The lungs evolved to receive conditioned, enriched air from the nasal passage. The oral bypass delivers raw, unconditioned air, adequate for gas exchange during exertion, entirely inadequate for the overnight cardiovascular recovery that depends on the vasodilatory molecule. The nasal passage was specifically designed to collect and deliver to the pulmonary vascular bed with every inhalation cycle. But the number matters less than what the gas does when it arrives, and what happens to the pulmonary vasculature when it does not. Nitric oxide reaching the pulmonary capillary beds triggers smooth muscle relaxation in the walls of the pulmonary arterioles, the small vessels that control blood flow distribution through the lungs. The mechanism is the same vasodilation operating in systemic arteries, now working in the pulmonary circuit. Dilated pulmonary vessels reduce pulmonary vascular resistance, the narrowness of the lungs' blood vessels, which determines how hard the right side of the heart must pump to push blood through the lungs and back to the left side. When resistance is low, the right ventricle pushes blood through the lungs with minimal effort. Oxygen exchange occurs across maximally dilated capillary beds. The alignment between where air goes in the lungs and where blood flows. Ventilation-perfusion matching optimizes. The heart's workload during sleep drops to its lowest sustainable level. Right ventricle is the thinner-walled chamber, built for the low-pressure pulmonary circuit, generating roughly 1/5 the pressure of the left ventricle that drives blood through the systemic circulation. The design reflects the physics. The lungs are centimeters from the heart. The systemic organs are meters away. The left ventricle generates approximately 120 millimeters of mercury to push blood through the entire systemic circulation, from aorta to capillary beds in the toes and back. The right ventricle generates approximately 25, just enough to traverse the short pulmonary circuit. The pressure ratio between the two chambers is roughly 5:1, and the wall thickness ratio matches. The right ventricle is an efficiency pump, not a power pump. It operates within a narrow pressure window, just enough to push blood through the dilated pulmonary capillary beds and back to the left side. When pulmonary vascular resistance increases, when the vessels that should be dilated by nitric oxide remain at baseline tone or constrict, the right ventricle must generate more pressure per beat. The thin-walled chamber was not designed for sustained pressure loading. The heart compensates by thickening the right ventricular wall, the hypertrophic adaptation the left ventricle undergoes in systemic hypertension. Right ventricular hypertrophy from chronic pulmonary vasoconstriction during sleep develops gradually over years without symptoms you would recognize as cardiac, without chest pain, without shortness of breath at rest. The right ventricle thickens silently, adapting to a load that arrives every night and disappears every morning, detected only when an echocardiogram happens to examine the right side, which routine cardiac screening rarely prioritizes because the left ventricle receives most of the clinical attention. But the thickening is only the structural cost. The cardiovascular recovery the heart was supposed to receive during those hours, the window that determines whether the arteries repair or accumulate damage, is the functional cost the non-dipping pattern reveals. You know the gas, the factory, and the passage, the mouth bypasses. The question shifts from what the lungs lose when the air takes the wrong route to what the heart loses when the recovery window, it depends on, never opens. But the right ventricle's nightly struggle is not the endpoint. It eliminates the recovery window the entire cardiovascular system was counting on. This is the mechanical basis of what cardiovascular medicine calls the nocturnal dip, the 10 to 20% decrease in blood pressure that healthy sleepers experience during the night. The dip is actively produced by the vasodilatory cascade that begins in the paranasal sinuses, travels through the nasal airway on each inhalation, reaches the pulmonary vasculature, reduces right ventricular workload, and allows systemic blood pressure to settle to its recovery baseline. The dip is the cardiovascular recovery window, the only sustained period of reduced cardiac demand, during which the heart, the arteries, the left ventricle, and the vascular endothelium experience reduced mechanical stress. Endothelial cells, the single cell lining of every artery, undergo repair during periods of low shear stress. High shear stress during the day damages the endothelial surface. Low shear stress during the nocturnal dip allows endothelial progenitor cells to adhere, proliferate, and replace the damaged cells. Endothelial damage accumulated during 16 hours of daytime circulation carries over into the next day, and the next day adds its own damage on top of the unrepaired surface. The arterial wall ages faster in non-dippers. The difference between a dipper and a non-dipper over 20 years is the difference between an engine that gets serviced every night and an engine that runs continuously without maintenance. Both engines accumulate wear from continuous mechanical stress. Only one receives the overnight repair cycle. The arterial stiffness that develops in non-dippers, the loss of vascular compliance that raises systolic pressure and widens pulse pressure, is partly the consequence of endothelial damage that accumulated faster than the repair mechanisms could address, because the repair mechanisms require low shear stress that the non-dipper never experiences. Dipping pattern was established as a cardiovascular prognostic marker by Hermida and colleagues in the European Heart Journal, demonstrating that patients who fail to dip overnight have significantly higher rates of left ventricular hypertrophy, stroke, and cardiovascular mortality than those who dip normally, independent of daytime blood pressure levels. The dip matters more than the daytime number. The clinical significance is striking. A patient whose daytime blood pressure is perfectly controlled at 120/80, but whose nocturnal pressure fails to dip, has a higher cardiovascular risk than a patient whose daytime pressure runs slightly elevated but who dips normally overnight. Your morning blood pressure reading that consistently runs higher than your evening reading may be seeing the signature of a lost dip. The pressure that should have descended overnight stayed elevated, and the morning measurement captures the system that never received its recovery window. The physician who measures blood pressure at a single office visit during the afternoon cannot detect the non-dipping pattern. Only overnight ambulatory monitoring or continuous home monitoring, wearing a cuff that inflates automatically every 30 minutes through the night, reveals whether the dip occurred. Most people have never once had this measurement taken. But the dry mouth at 6 in the morning is a surrogate marker, imprecise, unquantified, but directionally reliable. If the mouth is dry, the air bypassed the factory. If the air bypassed the factory, the pulmonary vasodilation was reduced. If the vasodilation was reduced, the dip was compromised. The dry mouth is the accessible signal for an inaccessible measurement. Now, the night I checked my own blood pressure data from the continuous monitor I had been wearing for an unrelated cardiovascular tracking project, the pattern was visible across 3 weeks of recordings. The nasal strip, the adhesive band that mechanically widens the nasal valve by pulling the lateral wall outward 2 to 3 millimeters, reduces nasal airway resistance by up to 30%. The nights I wore it, the nocturnal dip averaged 14%. The nights without the strip, when my partner confirmed my mouth had been open for most of the night, she could hear the dry breathing pattern change from nasal to oral within the first hour of sleep. The dip averaged 6%. 14% versus 6%. The difference between cardiovascular recovery and cardiovascular load determined by which passage the air used. Same person, same bed, same sleep duration, same medication, same daytime pressure, same stress level, same evening meal. The only variable that changed was the airway the air used and the gas it collected or bypassed on the way to the lungs. The monitor did not know which nights I wore the strip. The blood pressure did. The data separated into 2 distinct clusters as cleanly as if 2 entirely different cardiovascular systems had produced them on alternating nights, and the separation tracked perfectly with the airway, not with any other variable I could identify. Well, the direction of the effect is consistent with the physics. The proportional contribution of nasal NO delivery to the nocturnal dip relative to autonomic nervous system modulation and sleep architecture effects has not been isolated in a controlled trial. The mechanism is inferred from the physiology. The gas dilates pulmonary vessels, nasal breathing delivers the gas, mouth breathing does not, but the precise magnitude of the NO-specific contribution to dipping remains unmeasured. The anatomy and the pharmacology leave little ambiguity about the direction. The magnitude awaits a study that isolates nasal NO delivery from the other variables that influence overnight blood pressure. And then, the cardiovascular cost compounds because mouth breathing eliminates NO delivery while actively worsening the airway conditions that cause the mouth to open in the first place. The oral airway delivers unhumidified air, Air that has not been conditioned by the nasal turbinates, which warm and moisturize inhaled air to approximately 37 degrees Celsius and 95% relative humidity before it reaches the pharynx. Air entering through the mouth arrives at the pharyngeal surfaces cool and dry. A full night of dry airflow across the pharyngeal mucosa produces measurable tissue dehydration. The mucosal lining loses water content, the surface tension changes, and the tissue stiffness increases. Oral breathing significantly increases upper airway resistance compared to nasal breathing, through the combined effects of pharyngeal dehydration and altered tongue position, as Lee and colleagues documented in the laryngoscope. Stiff, dehydrated pharyngeal tissue is more susceptible to Bernoulli effect collapse. The negative pressure generated by inspiratory airflow through a narrowed passage meets a pharyngeal wall that has lost the pliability to resist inward deformation. The collapse threshold drops, vibration begins at lower airflow velocities, and partial obstruction occurs more readily. The physics is measurable. Pharyngeal closing pressure, the negative pressure at which the pharyngeal airway collapses, shifts towards zero in dehydrated tissue. A healthy, well-hydrated pharynx might resist collapse until negative pressure reaches minus 15 centimeters of water. A dehydrated pharynx, a full night of unhumidified oral airflow across its surface, might collapse at minus 8. The margin between normal inspiratory pressure and collapse pressure narrows with each hour of drying. By the 6th hour of mouth breathing, the pharyngeal tissue has lost enough surface moisture that the collapse threshold sits within the range of normal inspiratory pressure fluctuations. The vibration the partner hears at 4 in the morning, the snoring that was absent at midnight, is the sound of tissue that started the night, with adequate hydration reaching the dehydration threshold where Bernoulli effect collapse becomes mechanically inevitable. Mouth breathing primes the tissue for that collapse, drying the surfaces, stiffening the walls, lowering the threshold at which the Bernoulli pressure differential overcomes the tissue's structural resistance. Causal sequence is self-reinforcing. Mouth opens, mucosa dries, tissue stiffens, collapse threshold drops, and pharyngeal narrowing begins. Airflow velocity through the narrowed passage increases, because an identical volume of air must pass through a smaller opening. Increased velocity produces greater negative pressure on the pharyngeal walls. The Bernoulli effect scales with the square of velocity. Greater negative pressure produces further collapse. The jaw drops wider as the body compensates for the reduced airway by recruiting the oral passage more completely. Wider jaw opening increases pharyngeal drying. The cycle accelerates through the night, each hour of mouth breathing producing tissue conditions that make the next hour worse. You wake at 3 in the morning with a mouth so dry the tongue adheres to the palate. You are experiencing the cycle at its most advanced stage. The pharyngeal tissue has been drying for 5 hours. The collapse threshold has been dropping for 5 hours. The snoring that may have started as occasional positional vibration at midnight has progressed to sustained obstructive breathing by 3. The body responds to the partial obstruction by arousing slightly, not enough to wake fully, but enough to increase muscle tone, reopen the airway, and restart the cycle from a partially recovered baseline. These microarousals fragment sleep architecture, reducing the proportion of deep slow-wave sleep. The sleep stage during which growth hormone release peaks, tissue repair accelerates, and the glymphatic system clears metabolic waste from the brain. The oxygen saturation drops during these obstructive episodes. Brief desaturations from the normal 96 to 98% down to 90 or 88%, each one triggering a sympathetic nervous system surge that raises heart rate and blood pressure precisely during the hours these measurements should be at their lowest. The pulse oximeter you wear overnight would show a sawtooth pattern, saturation dropping during the obstruction, recovering during the microarousal, dropping again during the next obstruction. A pattern cardiologists recognize as the signature of sleep disordered breathing and one of the strongest modifiable risk factors for atrial fibrillation in the over 60 population. You wake feeling unrested despite spending a full night in bed, describing the fatigue to your physician as, "I sleep, but I don't recover." Maybe describing the subjective experience of a night spent cycling between obstruction, desaturation, microarousal, and partial recovery, never reaching the sustained deep sleep the cardiovascular system requires for its dipping window. The mouth breathing that began as a cardiovascular problem through NO bypass has now become a sleep quality problem through airway obstruction, and both problems compound across the full overnight period through one initial mechanism: the jaw opened. Now, beneath the jaw, the tongue position determines whether the cycle begins at all. The tongue has a correct anatomical resting position. Pressed flat against the hard palate, the tip resting just behind the upper front teeth, the body of the tongue in broad contact with the roof of the mouth. In this position, the tongue creates a seal between the oral cavity and the airway. The jaw stays closed because the tongue's upward pressure against the palate holds it shut, the way pressing your palm against the underside of a table lid holds it closed without a latch. The primary muscle maintaining this position is the genioglossus, the largest extrinsic tongue muscle, anchoring the tongue body to the inside of the mandible at the chin. During waking hours, the genioglossus maintains tone through habitual use. The tongue presses against the palate during swallowing, during speech, during the resting intervals between these activities. During sleep, muscle tone decreases globally. The genioglossus loses approximately 40% of its waking tone during non-REM sleep, and significantly more during REM. If the muscle's waking tone was strong enough that a 40% reduction still maintains palate contact, the tongue stays up, the seal holds, the jaw stays closed, the air routes through the nose, the sinuses deliver their gas, the pulmonary vessels dilate, the dip occurs. But if the waking tone was marginal, weakened by years of habitual mouth breathing, by a low tongue posture during the day, by chronic nasal congestion that trained the tongue to rest on the floor of the mouth rather than the palate, the sleep-related reduction drops the tongue below the threshold. The seal breaks, the jaw opens, the tongue falls posteriorly toward the pharyngeal wall. The nasal bypass begins, the NO delivery stops, and the dehydration cascade starts, and the heart begins working through its recovery window instead of resting through it. Tongue position during waking hours predicts tongue position during sleep. Habitual palate contact maintains the genioglossus tone that holds the seal overnight. The daytime habit is the muscular prerequisite for the nocturnal seal that determines which airway the body uses for the full sleep period, and whether the cardiovascular recovery window opens or remains closed. Connection runs from tongue to heart, and the prescription that lowers daytime pressure cannot reach the nocturnal cause. The medication works during the 16 waking hours when the body is upright and active. The tongue position determines what happens during the sleeping ones, and the sleeping hours are the hours the heart needs most. If chronic nasal obstruction exists, deviated septum, nasal polyps, chronic rhinitis producing persistent mucosal swelling, the nasal pathway must be cleared before the tongue position or the mouth tape matters. Saline rinse before bed clears acute congestion. Persistent structural obstruction requires evaluation by a physician. Taping the mouth closed while the nasal passage is obstructed forces breathing against resistance and is contraindicated. The mechanics worsen with age, and the person over 50 is the most affected. Genioglossus tone decreases with age as part of the general sarcopenia that reduces skeletal muscle mass throughout the body. The tongue is a muscular organ, and it loses cross-sectional strength at a comparable rate to the limb muscles. A genioglossus that maintained palatal contact through the sleep-related tone reduction at 35 may fail to maintain contact through the same reduction at 60. Because the baseline waking tone has decreased by 20 to 30% from age-related muscle loss. The margin between waking tongue tone and the sleep reduction threshold narrows with each decade. Simultaneously, the nasal passage narrows. Mucosal tissue thickens with age, the nasal valve loses cartilaginous support, and nasal resistance increases. The combination means you face both a weaker tongue seal from age-related genioglossus atrophy and a higher nasal resistance from mucosal thickening and cartilage loss. The two prerequisites for nocturnal mouth breathing converging at precisely the age when the cardiovascular consequences of a lost nocturnal dip are most dangerous and most difficult to reverse. The tongue can be retrained. The nasal passage can be cleared. The convergence is not inevitable, but it is the default trajectory for every adult who does not actively intervene against the age-related decline in both systems. Nasal pathway comes first, the tongue position comes second. The tape, a single strip of porous hypoallergenic surgical tape, placed vertically across the center of the lips, not sealing the mouth shut but providing enough tactile feedback to remind the nervous system to keep the jaw closed, comes last. Physics of why the sequence matters. Tape without nasal patency forces the respiratory system to breathe against increased nasal resistance, which generates greater negative pharyngeal pressure, which increases Bernoulli effect collapse risk. The opposite of the intended effect. Type without tongue training means the genea glossus drops during sleep, the tongue falls posteriorly, and the jaw strains against the tape rather than being held closed by the tongue's palatal seal, creating jaw discomfort that disrupts sleep. The tape works only when the two prerequisites are met. The nasal passage is clear enough that nasal breathing requires no conscious effort, and the tongue rests on the palate habitually enough that the genioglossus maintains sufficient tone through the sleep-related reduction to hold the seal. Every one of those breaths counted, the full nightly total of breaths, each one either collecting the molecule from the sinus factory or bypassing it through the oral route. The heart does not know why the pulmonary vessels stayed narrow. It does not know why the recovery window it was promised never arrived. It knows the resistance was higher than it should have been, for 8 hours, every night, for years. The gas that should have dilated the pulmonary vessels sat unused in the sinuses, while the air took the wrong passage and the right ventricle pushed against resistance. It was never designed to sustain during sleep. The blood pressure that should have dipped held steady through the hours the cardiovascular system counts on for recovery. Two systems failed simultaneously through a single mechanical event, the jaw opening. The pulmonary vasculature lost its dilatory signal, and the pharyngeal airway lost its hydration. The cardiovascular cost and the airway cost compound, because they share a single cause and worsen each other. The pharyngeal dehydration from mouth breathing increases airway resistance, which increases the work of breathing, which elevates sympathetic tone, which further prevents the nocturnal dip, the lost NO delivery already compromised. The two pathways converge on the same outcome, a heart working harder than it should during the hours it was supposed to recover. Through mechanisms that are independent in their physiology, but inseparable in their origin. The physician who prescribes antihypertensive medication based on an elevated morning blood pressure reading is treating the downstream consequence of a nocturnal event the prescription cannot reach. One jaw, one tongue, one passage bypassed. The jaw relaxed. The tongue dropped. The air chose the passage without the factory. And the cost accumulated, not as a crisis but as a nightly deficit, compounding across years, measured in cardiac workload the heart carries through the hours it was supposed to rest. 20 years of mouth breathing. 7,300 nights. 42 million breaths that bypassed the factory, each one a bolus of vasodilatory gas that accumulated in the sinuses and sat unused while the pulmonary vessels held their tone and the right ventricle worked steadily through its rest. The dry mouth was the symptom and the sore throat was the warning. The jaw was open the entire time, the tongue was down.